In this PowerPoint, we're going to take a look at psychiatric disorders and how they affect sleep. There are probably some misconceptions about various psychiatric disorders and their effect on sleep, and hopefully this PowerPoint will clear them up. Let's go on to our next slide. There is an intimate relationship between emotional functioning and sleep. Psychiatric illness can have a negative impact on sleep, as well as the medication to use to treat those conditions may have an impact on sleep or its sleep structure. Let's go on to our next slide. Major depressive disorder is a mood disorder. It has to have symptoms which last at least 2 weeks in order for diagnosis. It includes a depressed mood, fatigue, weight loss or weight gain, difficulty sleeping or sleeping too much. So insomnia or hypersomnia. These patients usually have feelings of inadequacy and guilt and suicidal thoughts. There is a lifetime incidence of 8 to 12% in men and 20 to 26% in women. The subjective sleep complaints of those with MDD are reported in 80% of the patients. Now, in regards to insomnia alone, sometimes insomnia can lead to the diagnosis of depression even though the patient doesn't have the other symptoms. This may cause an overdiagnosis of depression in some patients with insomnia, and this is due to a lack of understanding of the other causes of insomnia. There's also an erroneous belief that antidepressants are good hypnotics, so regardless if they're depressed or not, let's go ahead and give them an antidepressant and maybe their insomnia will be cured or treated. So insomnia not always indicates that a patient has depression. It's often misdiagnosed that way. Let's go on to our next slide. Let's talk about REM and depression. Total or partial sleep deprivation can result in significant improvement in depressive symptoms in 40 to 60% of the patients. However, unfortunately, this is a short-lived effect with only 50 to 80% of responders having partial or incomplete relapse after recovery of their REM sleep. So you deprive them of sleep for a little while, they seem to feel better, and then once they recover that REM sleep, their symptoms return. REM sleep changes are among the most robust findings in depression, so there's a high correlation of issues with REM sleep and depression. Unmedicated patients have a shortened REM latency, only 30 to 50 minutes in those with depression, as compared to 90 minutes in those without depressive symptoms. There may be an increase in REM density, and I'm going to show you a few examples of that here in a few minutes. Some studies show that the first REM period is longer and has a higher REM density than later REM periods in the person who is depressed. Interesting to note, because these patients have early onset REM and higher REM density, antidepressants, which are used to treat depression, are usually potent REM suppressors, so it actually prevents them from going into REM. Let's go on to our next slide. We're just continuing on about REM and depression here. REM latency may be a trait marker. Again, patients with depression typically go into REM much earlier and have a higher density of REM. The first-degree relatives of patients with depressed symptoms may also have a shortened REM latency, and abnormal REM changes are often seen during remission. REM latency is associated with an increased risk of developing depression rather than actively manifesting the disorder. Let's go on to our next slide. Okay, here's a hypnogram with a patient who has depression, and if you'll notice, look at the early onset REM and look how much they're having in the first half of the night. It's in that bold red line there, and they go into it about midnight and they stay into it about 12:30, 12:45, and then they go back into REM again shortly before 2, but this time their REM period is much shorter, and then as the night goes on, around 3:45, they have another short period of REM. So they're having more REM early on in the night and less REM later in the night, which is complete opposite of what a normal histogram would show. Let's go on to our next slide. This is a patient on antidepressants. They're on fluoxetine, which is Prozac, and they're on 20 milligrams. Notice this person's REM latency isn't for 196 minutes, so over 2 hours into the night before they go into REM. They do have a higher amount of REM right there at their first REM period. Notice their second REM period is shorter, and again, it's highlighted in red there. Let's go on to our next slide. This is what we're talking about when we talk about high REM density. The top picture of the EEG, notice how much of those rolling eyes are really or rapid eye movements, I should say, they're really, really going to town. Whereas the low REM density, you see a few eye movements. That's what they're talking about when they're talking about REM density. Let's go on to our next slide. Okay, the subjective complaints of major depressive disorder, 80% of them complain about their sleep. They complain either of difficulty falling asleep or difficulty staying asleep, so either onset insomnia or sleep maintenance insomnia. They also have some early morning awakenings with difficulty returning to sleep. They complain of insufficient sleep time. They complain of non-restorative sleep and disturbing dreams. Sleep disturbance can occur before the onset of other symptoms. So that's where they have the question, does sleep cause the depression, the lack of sleep cause the depression? Because usually they have sleep problems before they really start feeling poorly. Insomnia occurred as the first symptom in 41% of the initial cases of MDD and the first symptom in 56% of relapses. This is in contrast to anxiety disorders, where the insomnia complaint typically begins after the onset of anxiety symptoms. So depression, insomnia comes first, and then they feel depressed. And with anxiety, anxiety starts, and then they start having sleeping problems. Let's go on to our next slide. MDD PSG findings. These are our objective findings. This is what we actually measure when we do a polysomnogram. We notice that they have prolonged sleep onset latency. They have bouts of intermittent wakefulness throughout the night, so sleep fragmentation, and more wake after sleep onset. They have increased stage N1, decreased stage N3. They have shortened REM latency. Again, it's between 30 and 50 minutes versus 90 minutes in someone who's not depressed. And they have that increased REM density where they have lots of rapid eye movements. The first REM period may be longer than later REM periods with a higher REM density. Let's go on to our next slide. Okay, now we're going to take a look at bipolar disorder. This includes the alternating pattern of two emotional extremes, depression and euphoria. With MDD, which we were just talking about, sometimes they call that unipolar depression, meaning there's only one emotional extreme and it's depression. So bipolar disorder, they have depression and euphoria. There's a lifetime prevalence of 2.8 to 6.5%. Bipolar or hypomania could include about 50% of the people who are diagnosed with major depressive disorder. There is no gender difference for bipolar 1, but for bipolar 2, it shows female predominance. I just have a diagram there that shows that severe mania and then hypomania and then where they're supposed to be at their normal balanced mood, and then it goes into mild to moderate depression to severe depression. And these are the swings of bipolar disorder. Let's go on to our next slide. The subjective findings in patients with bipolar disorder, about 70% of them report sleep problems. During the depressed phase, the bipolar patient is more likely than the unipolar depressed patient to report hypersomnia. This was not objectively confirmed on MSLT, though, so when they went and tested them, they didn't find that they fell asleep faster or went into REM sooner. During the manic phase, sleep may be severely curtailed, but patients have little concern about their sleep. So they actually have less sleep, but they don't complain of insomnia. So they don't complain that they'd like to sleep and they can't sleep. It's just they sleep less. They spend less time trying to sleep and less time sleeping overall. With their PSG findings during their manic phase, you're going to have a decreased total sleep time, increased wake in the last 2 hours of the night, a short REM latency, and an increased REM density. Manic episodes may be preceded by a period of sleeplessness. Some concern that sleep deprivation may trigger mania, but this has been unproven so far. Let's go on to our next slide. Seasonal affective disorder. This is when the depressive symptoms begin in the winter and then they improve in the spring. Symptoms also improve when the patient is exposed to daylight or bright light therapy. This differs from MDD in that there is an increase in appetite and an increase in the need for sleep. More commonly, this occurs in young adults and particularly women. Sleep disturbances are a primary component of SAD. Most often reported symptom is hypersomnia. 80% report winter hypersomnia, 10% report insomnia, and 5% report both insomnia and hypersomnia. In those with SAD, total sleep time increased by 2.7 hours in the winter month compared to spring and summer. However, 50% of the general population also increase their sleep time up to 2 hours during the winter. So just the increase in sleep time can't be used for diagnosis alone. Let's go on to our next slide. The PSG findings in seasonal affective disorder increase a decreased sleep efficiency, decreased stage N3 sleep, normal REM latency, increased REM density. These findings were consistent when compared to themselves in the summer and following bright light therapy and in normal controls. Let's go on to our next slide. Sleep studies in the depressed patient. Untreated patients may have significantly decreased sleep time, limiting the time available to assess other sleep disorders. Medication may change their sleep architecture, confounding a diagnosis. So, for example, fluoxetine can cause rapid eye movements in non-REM sleep. REM suppression may decrease the likelihood of REM sleep in MSLT, may exacerbate RLS and PLMS, and it may mask mild sleep apnea. So once these patients have been put on a medication, it's going to be hard to tell how their sleep architecture is affected. Let's go on to our next slide. Now we're going to take a look at some different anxiety disorders. The different classifications of anxiety disorders include generalized anxiety disorder. This is where there's an excessive and long-standing anxiety, not focused on any particular object or situation. Panic disorder, which is a recurrent, intense panic attack without an obvious cause. Phobias, which include an intense, irrational fear of an object or situation that is not likely to be dangerous. Obsessive compulsive disorder, this is where there's persistent, unwanted thoughts that may be motivate repetitive behaviors. Post-traumatic stress disorder, which is stress reaction to severe trauma. Let's go on to our next slide. This diagram just shows that there's an overlap between major depressive disorder and anxiety disorders. I like this slide just because it shows how they can bounce off each other. Let's go on to our next slide. Anxiety is a state of cortical and peripheral arousal that can make sleep difficult. 50 to 70% of patients with generalized anxiety disorder report difficulty both falling asleep and staying asleep. So they complain of sleep onset insomnia and sleep maintenance insomnia. So you can see how the complaint of insomnia can easily be misdiagnosed for depression or an anxiety problem. Objectively, though, we see an increase in sleep onset latency, an increase in stage N1, an increase in arousals in the first half of the night, a decrease in stage N3 sleep, a decrease in total sleep time, a decrease in REM density, normal REM latency, and sleep deprivation does not improve symptoms in these patients. Let's go on to our next slide. With panic disorders, the sleep complaints are similar to generalized anxiety disorder. Exceptional difference is that they have a presence of panic attacks. 69% of panic disorder patients have had an attack during sleep, and 33% report recurrent sleep panic attacks. The attacks have no dream content or vivid imagery, so no nightmares, and they have a full awakening from the attack. They do not have confusion, and they can remember it. So it's not a sleep terror issue. It's they full-on remember everything. Objectively, panic disorder patients have panic attacks from N2 to N3 sleep. If frequent attacks occur, the patient may develop a phobia of sleep or a fear of sleep. Objective symptoms include increased sleep onset latency, an increase in movement time, a decrease in sleep efficiency, a decrease in total sleep time, a normal REM latency, and a normal REM density. Let's go on to our next slide. Phobias. Sleep complaints are rare in phobias unless the phobia is related to sleep itself. Panic attacks can lead to a sleep phobia as a means of avoiding the panic attack itself. In most phobias, sleep is normal. Let's go on. With obsessive compulsive disorder, most report poor sleep quality. However, in objective findings are that there's decreased total sleep time, a decrease in REM latency, a decrease in N3 sleep, a decrease in sleep efficiency, and an increase in awakenings. Sleep is very similar to the major depressive disorder patients and may also suggest that OCD patients have a depression component to the condition. Let's go on to our next slide. Post-traumatic stress disorder. These patients report of poor sleep. They have difficulty initiating sleep. They have more awakenings. They have poor sleep quality, and they will experience nightmares. Objective data have increased awakenings, a decrease in stage N3. Some studies found no sleep changes at all. the amount of substance abuse, psychiatric comorbidities, degree or types of trauma, and patient demographics may substantially differ in patient populations. Nightmares are commonly reported by 52% of combat veterans with PTSD compared to 4.8% of combat veterans without PTSD. Some studies found that some REM changes. PTSD nightmare may be a flashback and not necessarily REM related. There's a high rate of OSA in PTSD patients, and PTSD symptoms improved with the treatment of the apnea. Let's go on to our next slide. Sleep studies in the anxious patient. Stressors may exacerbate the anxiety, and a sleep study is a stressor. So you really have to take some care with these patients and really work carefully with them. The technologist's interpersonal skills are most important with the anxious patient. Desensitizing to a CPAP mask as well as the electrodes and the other hookup equipment well before the study will help. Muscle tension artifact in the EEG may make the sleep onset difficult to determine, and if you've ever had a patient with anxiety, you would recognize this because you think they're asleep, but there's so much muscle tension in your EEG waveforms that it's hard to tell. But usually once they hit stage 2, they relax more, and then their EEG is much easier to visualize. Sleep-related panic attacks may include symptoms similar to a heart attack. Take these symptoms seriously and do not assume they are psychiatric related. Respond in an appropriate medical manner. Many patients with anxiety are taking benzodiazepines. Benzodiazepines on themselves are going to affect their EEG as well as their sleep architecture. It suppresses N3 sleep, decreases their parasomnias, it decreases arousals, including arousals to periodic limb movements, and it may slightly worsen sleep apnea. Let's go on to our next slide. Schizophrenia is a psychotic disorder considered one of the most severe and disabling of all mental illnesses. Worldwide, the prevalence is about 1%. There doesn't seem to be a gender difference. Severe symptoms of the illness dwarf sleep complaints, but sleep can be severely disrupted. Dreaming can be thought of as a model for psychosis. So if you think about when you dream, that's what a schizophrenic person is experiencing or similar to. Patients report that their sleep is more disrupted during psychotic episodes. Sleep is better during remission, but problems of falling asleep and staying asleep still remain. And this group reports a higher frequency of nightmares, as do highly creative non-schizophrenic individuals. So, non-schizophrenic individuals who are highly creative also have nightmares to about the same extent of patients with schizophrenia. Let's go on to our next slide. The objective findings with schizophrenia, most reliable changes are found in non-REM sleep. Most studies find a significant reduction in delta activity. There is an inverse correlation between delta activity and the severity of negative symptoms such as affective flattening and impoverishment of speech. These non-REM findings were stable over time and may reflect a trait measure. On your PSG, you see an increase in sleep onset latency, an increase in wake after sleep onset, increased number of awakenings, decreased total sleep time, decrease in sleep efficiency, decrease in delta wave counts, and REM latency was slightly decreased or normal. Let's go on. Sleep studies in the psychotic patient. Sleep studies in actively psychotic have research interest but little clinical utility. Clinical sleep studies will typically be performed when the patient is either in remission or medicated. The interpersonal skills of the technologist are very important. It may be difficult to explain the procedures, and there may be concerns that the equipment is doing more than explained, such as reading their mind or inserting thoughts. They're very consumed with what's really happening and what you're not telling them. Let's go on to our next slide. Alcoholism. Ethyl alcohol is the second most commonly used psychoactive substance in the world. An adult can metabolize 1 ounce glass of 80 proof whiskey, a 1 ounce glass of wine, or a 12 ounce can of beer in 1 hour. With acute alcohol ingestion on the first half of the night, you're going to see a decreased onset latency. It may suppress REM sleep during the first half of the night in a dose-dependent manner. So the more they have, the more it's going to suppress REM. It also may increase at stage N3 sleep. However, in the second half of the night, it's going to increase their stage N1, increase their awakenings, and they may experience REM rebound. When nightly dosing, tolerance to these effects may develop within 3 days. So if someone drinks night after night after night, then their tolerance to the effects of alcohol may increase in just those 3 days. With chronic use, the patient may fall asleep rapidly, total sleep time is decreased, REM is largely suppressed, and most sleep is done in non-REM. The latter portion of the sleep cycle is fragmented, and patients often state they cannot fall asleep without alcohol. You can see how this is really tough for an alcoholic to stop drinking, because if they feel they can't fall asleep without it, at nighttime they're really going to have that craving for it, and it's really, really an obstacle for them to overcome. Let's go on to our next slide. Decreased N3 sleep, more frequent though shorter REM periods. REM is not increased. Sober alcoholics take longer to fall asleep and sleep for shorter periods of time. Sleep is fragmented with frequent brief arousals. Insomnia occurs in 36 to 72% of alcoholic patients. Insomnia may persist for months after beginning abstinence. Confounding factors include increased anxiety, depression, and tobacco use. Sober alcoholics have more sleep-disordered breathing and periodic limb movements during sleep. Insomnia during abstinence is associated with relapse, perhaps to initiate sleep. That goes along with what I was saying on the last slide. Since they experience so much insomnia, and when they do drink, they can fall asleep quicker, even though their sleep isn't as refreshing, it's hard for them to see the difference. So they think, I can't fall asleep without the alcohol, and that can cause a relapse. Let's go on to our next slide. Ethanol selectively decreases muscle tone in the upper airway and can lead to worsening of snoring and sleep apnea. The effect is more pronounced in men than women, and more pronounced in older men as compared to younger men. Alcohol may also blunt the arousal response so that the apnea and hypopnea events become longer. These negative effects are the strongest in the first 1 to 2 hours after alcohol consumption. An individual who routinely drinks at home but is abstinent on the sleep study may show less apnea. The use of alcohol may also bring into question the accuracy of a CPAP titration. Let's go on to our next slide. In summary, psychiatric patients are often a special challenge for the sleep technologists. These illnesses generally have negative effects on sleep. The medications used to treat these illnesses can also affect sleep architecture. This group of patients may test the interpersonal skills of the sleep technologist more than any other patient group. It is incumbent on the technologist to provide a calm, reassuring environment for conducting the sleep study. Explanation regarding the process of hooking up and conducting the study will help relax the patient prior to the study. Understanding the roles that psychiatric illnesses and medications have on sleep will allow an accurate interpretation of the sleep study and may provide some information on the patient's prognosis as well. Your tech notes will really come in helpful as well for your interpreting physician. If you notice a lot of rapid eye movements in REM, you can note that. If you notice increased number of spindles, please note that. Things like that can help the doctor take a closer look at areas of the study that he might otherwise overlook. And that concludes this PowerPoint.